a bit about who we are and what we do, what's our model, some of our key resources, some information about our MDTs and our approaches and processes. Because we're a strategic and operational network, some of the work that underpins that around our education and our quality improvement initiatives, and then what all that means in terms of value for our different stakeholders, from our patients, families and carers, for our staff, for our provider partners and for our commissioners as well. Next slide. Sorry, it seems to be stuck. Can you see that? I want to leave it on there. For my presentation. Has it gone to the next slide with a video? Has that changed slides? Can you see? Yeah, sorry. Okay, so what we thought we'd do is just start with an animation that we've got for the Rehab Network, which gives a nice overview of what I've just discussed there in terms of who we are and how we support our patients and families and carers. So we're just going to press play. If anyone can't hear us, hopefully this works, but please raise your hand or give us a shout.
We are the Cheshire and Merseyside Rehabilitation Network. We support people who've experienced a traumatic illness or injury along a pathway of care. We offer a range of services across hospital and community settings which can be accessed at any point during your rehabilitation. Your pathway will be tailored to meet your needs, and whatever happens, you'll have an amazing team of experts on hand 24/7 to work towards getting you home and reaching your potential. Here, we'll explain about how we work and the kind of support you can expect. When meeting someone new, we don't see a patient, we see a person. Rather than just looking at your medical needs, we look at who you are. For instance, who your family and close friends are, and what kind of job you do, your hobbies and passions, and any pet hates. Everything that makes you unique. This way, we have a much better idea of how to rebuild the whole you. Once you're onto the rehabilitation care pathway, there are lots of different possible routes, depending on your goals and needs, but the important stages are the same for everybody. First, there's admission and assessment. Then we work with you and your family to set realistic short and long-term goals. We'll start with small ones first and build up to bigger ones. By communicating with you, we can fine-tune them as you go along. At times, it may be frustrating and difficult, but we'll be there to give you the support, encouragement, and motivation you need at every stage. Because we're a network, your treating team is made up of lots of different people with different skills. All of them are specialists in rehabilitation for people who have had a traumatic illness or injury. We work together and are communicating all the time. The Rehabilitation Coordination Team are the first people you will meet, and they'll help guide you along the pathway from start to finish. You may also meet rehabilitation consultants, physiotherapists, occupational therapists, speech and language therapists, dietitians, psychologists, psychiatrists, nurses, vocational rehabilitation therapists, social workers, and all kinds of other health professionals and support staff. But everything we do will be tailored around you and your family's needs and wishes. Regular goal-setting meetings help us make sure your rehabilitation programme is on track, so we can help build the best possible future for you as fast as possible. As well as your physical and cognitive well-being, we will help you and your family with difficult emotions too, by offering a safe environment for you to talk about your feelings. Our ultimate aim is to help you be as independent as possible, and everything we do has our 6 values at the heart.
So in terms of our model, what we provide, we've got a hub and spoke model, which consists of a hyperacute rehabilitation unit, a hub, spokes, extended rehab, and then we've got community services as well. So in our inpatient bed base, we've got 103 beds. We work to a coordinated pathway to support our patients' rehab needs, as I say, from hyperacute right through to community. So within this region, having that pathway, which is quite unique to some other neuro rehab services nationally. Our approach is based on need, not diagnosis. Our service provision and our workforce, these are based on the British Society of Physical and Rehab Medicine standards. And all of our inpatient units, hub and spoke units, are fully accredited with the UK Rehabilitation Outcomes Collaborative. And we'll go on in a few slides, we'll kind of talk about what UK ROC is and what that means as well. Okay, so underpinning all our work is our vision and mission for the network. So our vision is about providing a high quality specialist rehab. We've mentioned it being a coordinated pathway across hyperacute community, and that needs, not diagnosis, is really important for the network and really key so that all our patients in the region can access that specialist level of rehab. Our mission is about working collaboratively, and that's about the network collaborative approach. It's working with our commissioners, working with all our provider partners, working with our patients and staff and families as well. So that ensures that specialist rehab care is then underpinned by evidence-based practice, research and innovation, and how that then enhances our patient outcomes. So as I mentioned, because we're a strategic network, a lot of the work that we do as well is supported through education and quality improvement. And again, we've got some slides further on in the presentation to outline some of the key initiatives that we're currently involved in with our teams. So one of the things we did when we first started the network, so the network has been established since 2013. Staff across the network felt it's really important that we had some network values. So these are complementary and work with each of our individual organisation values as well. So we work at the Walton Centre, so we work to our Walton values, but then within the network, we also work to our rehab network values. Staff working in, for example, Broad Green Spoke will work to Liverpool University Hospital Group's values, and then also the network. So these are 6 values that were developed with our staff and with our patient groups. So what they felt was really important was about working together to deliver quality patient and family-centred care. It was that commitment to quality, so that quality is at the centre of everything that we do and how we drive some of our quality improvement initiatives. And to support that, respect and dignity, empowerment, compassion, empathy, and honesty and trust. And similar to our Walton Centre, how we have annual awards, we also have our own network Living Our Values Awards, and that's about celebrating the work of our staff through the year in delivering specialist rehabilitation across the pathway. Some of our strategic objectives, so these each support our operational delivery of the network. So we manage the 103 inpatient beds and the community services, and then how we do that is supported through our strategy as well. So these are around strengthening our service pathway, delivering patient-focused services, continuously improving quality to deliver safe, effective and person-centred services, how we're enabling excellence to our staff, so it's about our education, training, workforce development, ensuring that everything we do is sustainable and that it's cost efficient as well. And you'll see through the slides further on in the presentation how some of our work is mapping to our strategic objectives as well. Okay, so this slide covers some of our stakeholders that the network works with. So obviously we've got our patients, families and carers, our clinicians and our non-clinical staff. But some of the wider stakeholders, so some of our patients come from major trauma, they'll come from critical care, and spinal. We do support some spinal patients into the network, and they'll start with us and maybe then go on to spinal injury, working with local NHS trusts, local community teams as well. I mentioned that the rehab network goes from hyperacute right through to community. So some of our patients will come into an inpatient unit and then through the community. Others may start their rehab within the community team. So it's important that our teams are working with local community teams there as well to identify the right patients at the right time as well. Other stakeholders, I mentioned our commissioners, local authorities. So within the network, we do have dedicated social workers as well. So as soon as a patient is with us, we'll start working if there's any social work issues and support that they need as well. We work with our charities, voluntary sector organisations as well, employers. So within our MDT, we've got vocational rehab therapists. So if our patients are looking to go back to education or to employment, our vocational rehab therapists will support them as well. It may be that our patients go back to the same role that they were in prior to their injury or illness. Others, the vocational rehab practitioners will work to kind of support them in an alternative employment as well. Our way to stakeholders is working with our clinical reference groups, various education institutions. We're working with the Liverpool John Moores, Liverpool University, Edge Hill through all our work as well that we'll just demonstrate later. Some of our research institutions, quality improvement organisations, innovation as well is integral to what we deliver, and media as well to kind of promote and share good practice. Okay, so in terms of our partners within the rehab network, so we've got 5 providers delivering that coordinated pathway across hyperacute community. We've got our commissioners, so that's NHS England and ICB, and then we're also working with our local place commissioners as well. And with our social workers, we work with Liverpool Local Authority and St Helens Local Authority as well. So the next slide is just a bit of a map around kind of where our services are based, from our hyperacute complex rehab hubs, our spokes, extended rehab, and our specialist rehab community services. And the next slide is just an image of where those units are based. So we've got units based at the Walton Centre, which is our hyperacute assessment rehab unit. We've got 10 beds there. We've got 20 beds in our hub complex rehab unit, 55 spoke beds, and they're across St Helens, the Walton Centre, Royal Green, and Wirral University Hospital. So some patients may come into a hyperacute and then go along the pathway into our hub, spoke, extended, and community. Like I say, depending on what that patient's needs are at the time, they're kind of guided by where their patient journey starts really. So those patients who come into our hyperacute assessment rehab unit, these are our patients who are still medically and surgically unstable. They may be coming from our hyperacute, maybe coming, from major trauma hyperacute, from spinal, from critical care, and that step down. Our CRU, which is the 20 beds in pink on the triangle, patients can be with us there up to 3 months, and this is around supportive rehabilitation. Our teams then are in our spoke supported active rehabilitation. So this is where our patients then become medically stable, still having complex MDT needs, but having that intensive rehab at that stage and working towards their improvement independence. And patients can be with us in our spokes up to 16 weeks. That's our commissioned pathway. Extended rehab is our unit that we've got over our gardens, which we've got 18 commissioned beds there. So this is where patients may need that slower stream MDT rehab, and patients can be there with us up to 18 months as part of their journey. So again, some patients may start off in our hyperacute unit and then go to our extended rehab to follow those goals through. And then we've got our community rehabilitation. Currently, our community rehabilitation is only for Merseyside patients, but our commissioning review that has just started in April is looking at that wider reach and how we link in with Cheshire and Wirral and wider regions as well. Because we're a network, we've got a network governance structure. So we're hosted by the Walton Centre with all our partners that I've mentioned earlier. But we do have our own rehab network strategic board. So in our board, that's the board that kind of manages and maps out our work programme for the year. The board's chaired by Dr. Andrew Nicholson from the Trust and Gary Price. And then we have other execs from all the provider organisations, commissioners are on that board, and then clinical leads as well on that board to identify what our work plan priorities are for the next year, review our performance and our activity, and then to understand where our quality improvement education focus and priorities need to be to support our staff and our patients and families. obviously within the rehab network, we've got some inclusion exclusion criteria. So just to briefly touch on some of this. So in terms of inclusion, I've mentioned the network is based on needs, not diagnosis. But it does need patients to have a level of rehab complexity needing 2 or more therapy disciplines. Our services are commissioned for adults aged 18 years onwards, although any patients between 16 and 18 are assessed on an individual basis. And then that's supported with our commissioners as well. And part of the inclusion criteria requires patients are able and willing to participate in and benefit from the rehab at the level of intensity provided. So if it's supportive rehab in our hub units, or it's the active rehab in our spokes, or more slow stream in our extended and community therapy, they do need to be able to benefit from that level of intensity in each of those areas. Exclusion criteria is any patients with rehab needs that can be met within existing specific rehab services. So we've got the spinal injury centre. So some patients, like I say, may start here and then move to Southport. But if their needs purely can be met by Southport spinal injuries, that's where they're best placed to be supported. There's other rehab services like stroke. While we do support some stroke patients, again, if their needs are best met within a stroke pathway, we'll signpost. Kelly and the team will signpost on there. Cognitive rehab needs only are supported through our Merseyside, our brain injuries centre, or any patients specifically with active severe mental health issues at the time wouldn't be able to access the rehab network pathway at that time as well. Okay, so in terms of our referral process, we've got, in terms of our inpatient specialist rehab, so referrals can be made by any healthcare professional. They're managed by the rehab coordination team, and specifically through all referrals go into a single point of contact. The single point of contact or the spot will then go and assess the patient's needs, discuss with their families, discuss with the referring team, and then present that back to the consultants and the MDT to identify if they would benefit from coming to the rehab network, and then what level of rehab would be best placed to meet their needs. All our referrals are discussed at weekly allocation meetings or before, if we can support that discussion and acceptance outside of those meetings as well. Similar process for our community specialist rehabilitation. So again, referrals can be made by any healthcare professional, and they're managed and coordinated by each of our locality team leads as well. And they're triaged by the team leads and discussed with the disciplines as well to support patients accessing timely rehab with our community services. All our 103 beds are managed by our rehab coordination service, supported through the single point of contact. We're constantly monitoring our admissions and discharges, looking at our pathway transfers to support our patients at the right time, at the right place, and getting that right level of rehabilitation. The coordination team supporting from assessment right through every patient once they're admitted is supported through a rehabilitation coordinator, from admission right through to discharge. That rehabilitation coordinator supports patients, families, and the MDT, so that key link. Our coordination team are qualified nurses and therapists. And then, like I say, we support working with our patients and families through from referral right through to discharge as well to manage rehabilitation needs. This slide is just touching on each of our services are supported by a multidisciplinary team. So each of our inpatient units are consultant-led, but then supported through our nurses, through our physios, occupational therapists, speech and language dietitians, psychology, psychiatry. So all those disciplines that you saw in the video at the beginning, and then with that coordinator being that key link as well. So patients and families, all the MTT can use that kind of resource there. I'm just going to hand over to Rachel now to touch on the performance, quality and education aspects of the network.
Thank you. So yeah, what we do in the network, I think it's a real benefit of working part of the network, is that we get a real unique opportunity to share our quality and safety measures outside of our provider organisations, and we can learn from each other as a network. So we use our nursing manager forum where we share and discuss all of these parameters related to quality and safety. So our falls, our incidents, our violence and aggression incidents, our mortality incidents, but also celebrating our kind of complaints and concerns, feedback from friends and families, and then we have a really engaging group who discuss these incidents, where we can then share and learn from each other as well. And then these are a few of our key performance indicators. So these are our KPIs that we're commissioned and monitored on. So things like our referrals, our waiting times, our activity, how complex our patients are, how long people are with us as well. And what we do in the network is, because we report on these and monitor these and review these quite closely, not just as a management team, but also with the clinical leads within the team. We really are able to use our KPIs and quality safety measures to really direct and inform our quality improvement projects, our service development initiatives, and also any education gaps for staff within the network as well. So Angie mentioned earlier on our UK ROC. So this is kind of the what makes us a specialist rehab network, and what makes us a registered pathway as well. So UK ROC is UK Rehabilitation Outcomes Collaborative. So it's a national database where every rehab service in the country inputs their data into. Every single care episode that the patient experiences is inputted into this central database across the country. And it's a set of tools and outcome measures that the clinicians use to look at individual needs for rehab, what they have had to meet their needs, but also their outcomes and how they've improved throughout their journey compared to when they first came in for rehabilitation. So the UK ROC team, centrally based at Northwick Park, they analyse all of our data for all of our units and then produce benchmarking reports. So we're able to see how we're performing in comparison to other similar units across the country as well. So to be classed as a designated and commissioned specialist rehab pathway, you must be registered with UK ROC. You must submit your annual service profile, which we're just about to do over the next few weeks, and provide a minimum data set of standards as well. And from that, rehab units get accredited from level 1 to 3, and that's just based on how each unit is based on how the complexity of patients that they receive as well. So our hyperacute unit is level 1A, our complex rehab unit and hub is level 1B, and then our spoke units are level 2, and our extended rehab is level 3. So anybody who is familiar with the network or works within the network will be very familiar with UK ROC and the importance of why we need to adhere to that to keep our accreditation as well. So Angie mentioned how linking through to our strategic objectives comes through in some of the work that we do. And one of the one that I think we're particularly proud of in the network, which I think makes us really special place to work, is how we enable an excellence through our staff. We know that education and training are critical enablers to sustain frontline services to meet the needs of our patients and our families. So we have a dedicated education and workforce development group that's made up of clinicians across different disciplines and services. And we have the governance and leadership structures in place to support staff education and training as well, to deliver on our strategic objectives as well. So our strategic board are really committed to adopting an education focus to deliver our vision and objectives and invest in our staff. And so every year we complete a network-wide training needs analysis for our staff and to identify what education resources we are providing with key topics, all to help improve patient clinical outcomes and experiences. So these are just a flavour of some of the education initiatives that we've developed. So we have an annual education and training programme that we provide for our staff, which provides clinical education on a variety of MDT topics in specialist rehab. And we've just recently developed and launched a nursing competency framework. So this is a framework which provides 16 domains of key clinical areas over 3 competency levels, which all of our registered and non-registered staff are working towards to demonstrate that they're competent and have the skills and knowledge to provide the specialist rehab nursing that our patients require. We've got a master's module in complex rehabilitation in the MDT context that we run jointly with Liverpool John Moores, and we're just in our 9th cohort of that, so we're halfway through that 9 master's module accredited programme there. And from that we've got a foundation level course which mirrors the topics of the master's module, but is for our entry level new to rehab and also non-registered staff as well. And then we've published a book in complex rehabilitation that you can see there on the screen. So this is just a flavour of what our education topics look like. This was just a snapshot of 1 year of all the things that we provided on MDT development, things around policy and government, through to patient-centred care, models and approaches, clinical interventions, and then network-specific development. And then from that, our wonderful team of education and data administrators provided us with this education and training calendar that staff can access and pick any course that they want to, that they think will benefit their role, all free of charge as well. So another key strategic objective for the network is how we continuously improve quality and the quality services that we provide to provide safe, effective and patient-centred services. So again, we have a dedicated quality improvement and transformation group, which again is made up of clinicians of different disciplines across all of our services to provide our strategic objectives. So we support policy improvement at a service level with our host providers, but also work done across the network and cross network quality improvement initiatives. We facilitate rollout and learning of successful quality improvement projects between teams and celebrate our quality improvement initiatives. We measure the impact our quality improvement initiatives have on patients, family, staff and services. We identify what training the staff need to be able to improve their services, and we embed a culture of listening to patients and their families to improve and learn together and engage patients and families in our projects. We have active patient forums where all of our quality improvement initiatives are kind of discussed or developed as well across the different units. So this year, our 9 quality improvement areas, where all of our projects had to link into one of these focused areas as well. So the big one that we focused on last year that will be brought forward into this year as well will be developing our 24-hour rehab approach, and our nursing competency framework will support that as well. Improving data clinical outcomes, how we embrace equipment and new technologies to provide our rehab, providing group therapy as well. So we've got some very successful groups in kind of mindfulness, the gardening group, family education groups as well is a huge part of the work that we provide across our units. Improvement patient care and experience, improving our PDOC pathway, which is a cohort of patients with prolonged disorders of consciousness as well, and the services that we provide to those patients, patients with spasticity challenges as a result of their their injuries and how we manage that as a coordinated pathway, how we comply with standard operating procedures, national guidelines, and then also looking at how we optimise patient transfers and discharges through the pathway as well. So one initiative that did come from our quality group is looking at how we use patient and family stories. So we completed feedback surveys. In the past, we've done a cinema showcase of patient stories, and then the team developed a patient stories map. So we wanted to be able to use our patient stories in many different ways as possible. So we've got a standard structure to collect patient stories, which follow the title of our initial CMRN, looking at their condition, MDT rehab, how they've reflected on their journey and what their next steps are. So we wanted to look at, when we get a patient story, how we use that for education and training, how it might improve, lead on to quality improvement projects, how we can use it to inspire our staff and celebrate the good work that they do, and also how we can promote that through conferences and awards as well. So I'll hand back to Angie to conclude our talk.
Thanks, Alicia. So yeah, through the presentation, we've looked at, like I say, what we do, who we are as a network, how our highly skilled MDTs and non-clinical staff support in our operational delivery and our educational quality initiatives, and then the values that brings, both for staff wellbeing and experience, and our patient outcomes and experience as well. And how the network supports that wider system as well. So supporting patient flow and blood pressures in acute to enable our patients to access timely rehabilitation. So going forward, it's continuing that work really through the network with our teams and with all our partners, looking how we continue to optimise outcomes for our patients, both across our pathway and, like I said, across the wider system as well. So some of the work that we're looking at is how we're supporting the right patient to be at the right place and at the right time. So Rachel mentioned some of the work we're doing with the coordination team. Kelly Hopkins is on this call. So Kelly is the Rehabilitation Coordination Service team lead. So doing a lot of work with our referrers to ensure that patients are identified early on as rehab so that they can benefit access to the network as early as possible. And then once patients are with us and they're developing and meeting their goals, say in the hub, that they're then able to kind of go along their rehab journey, whether that be to our spoke or to community. So they're following their journey as appropriate. Rachel mentioned PDOC, so our prolonged disorders of consciousness patients. So we do have a small service within the network, although it is very limited. So there's some work going on at the moment with commissioners, and which will be extended to referrers as well, just to understand what that demand is and then how we can support that in the network. There's national guidelines around what that PDOC pathway should be looking like as well. So once patients with that condition are with us and we can do that assessment and diagnosis, what their pathway and what their journey needs to look like as well. So like I said, that's the piece of work we're doing with our commissioners. The nursing competency framework that Rachel mentioned, that's been in development over the last couple of years, and we launched that in March across all our inpatient units. We're just working with the Royal College of Nursing for accreditation of that framework as well. So that's supporting, like Rachel said, all our non-registered to registered staff in competency development and specialist rehabilitation. Spasticity education, so this is a piece of work that we're doing in collaboration with Edgehill University. And what we're hoping to provide is that spasticity education for not only our rehab network staff, but then for acute and then care home staff, for families and patients themselves as well. And then how we're using, or how we could be using digital technology and AI to support in our work, both with our patients and then for our staff development as well. So thank you everyone for listening to our presentation. Any questions?
I've got a question, if that's okay. Carol Hopwood, one of the governors. In terms of, hiya, and really interesting for me to hear all of that, particularly my day job as a brain injury lawyer. So it's really interesting to hear all of that. I suppose two questions for me. One is in terms of bed availability, is that always kind of full, or is there capacity, or is it an ongoing struggle? And then two, and this is something that we come across quite often, is where people are having to access community care or continuing healthcare funding. Is there a provision in place to help people with that process? Because you will all know how difficult it is to access and be awarded continuing healthcare funding and assisting with appeals, etc. So we're quite often asked that question in terms of what support is there around. So do you do it, or who do you signpost to?
Thanks, Carol. In terms of bed availability, so as mentioned, we've got 103 beds across the pathway. We're doing a piece of work at the moment with our commissioners across our spoke provision. So we've got 55 beds across our spokes, including Walton, Broadgreen, St Helens and Wirral. And we were finding constantly that our Cheshire and Wirral patients were having to wait longer to go into Wirral. They've got 10 beds there. Whilst at the same time, we did have beds available in our St Helens and Broadgreen units. So we've done a piece of work, patient feedback, listening to that as well, listening to staff. And we're doing a 6-month pilot with our commissioners, whereby Cheshire and Wirral patients can also, if our beds are full at the Wirral, our Clatterbridge unit can then access earlier specialist rehabilitation in our other spoke units as well. So it's just, maximising that for the benefit of our patients, really, because we found when we started this pilot in March, we found that our first lady who was admitted to our St Helens spoke, had she have waited for a bed to become available in our rural unit, that would have been at least 8 to 10 weeks. So she's been able to have 8 to 10 weeks of rehab earlier on in our spokes. And we're still working through that pilot. It may be that patients start their rehab in St Helens or Broadgreen whilst they're waiting bed, depending on where they are in their rehab goals. They may then get transferred, if that's their request, to our rural unit, but we're still working through listening to patients, what's their experience. Appreciate it's out of area, but the feedback so far is, from patients and the families, is that earlier rehab and how beneficial that's been, really. We are looking at, as part of the commissioning review, looking at, although we're based on need, not diagnosis, there are still other opportunities. We mentioned the PDOC patient group, so there's some work there that how we can really support and maximise early rehab for some of the patients as well, and just looking at other kind of models how we can ensure everybody's kind of accessing that early timely rehab at the right place at the right time. In terms of CHC funding, I know my colleague Kelly is on the call. Kelly, are you happy to take that one for Carol?
Sorry, Angie, just repeat the question again. Sorry, I had a phone call going at the other side. Go on.
No, that's fine. Carol's asking about the CHC funding process and how the network supports that, and how your team works to support patients and through that CHC funding process.
Yeah, so when the patients are referred to us, then it'll depend where the funding comes to, which spoke unit that they can go in. And as Angie's explained there, if with the pilot scheme, it's very much Wirral and Cheshire go over to Clatterbridge, and then we've got funded beds by Warrington. Liverpool patients can access any. So we work and see where the patient's from, and it goes off the GP. The funding, it goes off where the GP is based on that.
Sorry, Kelly, I think I've asked the question in the wrong way. So what I was trying to get at is, so we get clients rather than patients who will talk to us about who can help us with a CHC funding application, for example. Is there someone that you guys can signpost to, because it's a that DST and all the rest of it, it's just a minefield, is it? Is there something within the rehab community or network where patients or clients can be signposted for support other than like the CAB?
I think it's just that, to be honest, we tend to, it'll be from the social worker aspect, and then depending on where they are, like we've had some West Lancs patients who come in and then it goes to them and we have to wait for their funding. We don't have an influence over that or actually put any form of that funding in place. It
No, I mean in
depends.
terms of physically applying. So like people saying to people, do you know CHC funding could be available? This is how you access it. This is how you fill in the application. That type of basic level assistance I'm talking about.
So we would have referred to Paul, who works for NHS England, but
Right.
he's not there at the moment. So anyone like that who would need that type of funding, we would refer to him for advice. But he's not in post at the moment. He's working to do our commission review at the moment, and there isn't actually anyone in post. So that's who we would use. So from your client's point of view, I think it would, if they went through the social worker and then they're local for advice.
Okay.
If that answered your
Thank
question.
you.
Sorry.
Okay, thanks.
Okay, thank you.
Any other questions?
No? Well, that's okay, because if anyone does think of any questions that they want to ask after the session has finished, feel free to drop me an email and I'll pass that on to Angie and Rachel, and then I'll pop the response through. So if you still got questions, drop me a line. Lastly, on here as well, I'm just going to share my screen again quickly. I just wanted to say thanks to everyone for joining us today. And after the session, I'm going to share a feedback form, if that's okay, for everyone who's in attendance. You'll be able to fill that in, and again, there's comments field on there. So if you've got any suggestions or anything specific that you want to hear about at a future event, then you're more than welcome to go ahead and pop the information on here. It'll be much appreciated. And I think Kelly's got a hand up again.
Yeah, Carol, just to go back to your question, if you want to drop me an email, I can then forward it on. I've just had a quick conversation with Paul and he's happy to help you with any signposting. Is that
Brilliant.
okay?
Yeah. I just
Send it,
Nicola,
send it to me,
yeah,
Carol.
send it to you, yeah.
And I'll
Is
forward
that
it
all
on for
right?
you.
Brilliant.
And then I'll signpost you on.
Excellent. Thanks.
Okay, thank you.
That's lovely. Okay, and again, thanks everyone for joining today. I really appreciate it. Thanks very much, and thanks Angie and Rachel as well for agreeing to do the session.
Thank you.
Thanks, Nicola. Thanks, everyone.
Thank you.
Bye.
Bye everyone.
Bye.